Welcome. Silvia is in charge of the event. I will take only 1 minute or two to welcome you. Has taken over some of the role. We changed the name to Ital. Italian actually means I-talenti. So we want to feature here events which are, target some verticals, and we plan to present. It's like an evening of study. And here we'll talk about how to introduce that are very dear to me. They have excelled in their field. And right here is Benedetta Di Robilant, a very interesting story at Stanford, professor of genetics, has an amazing curriculum, originally from Cambridge, UK, years ago. He was indicted to be all of an inventor, a teacher, and an entrepreneur. So we're going to hear not only the science of longevity, but the business of longevity. And I will give each presenter a few minutes to tell the story, and then we'll go, okay?
Years ago. Was doing possible. We never do that language. Medicine is no. That is Ogemica, and I'm investor in this company and Sylvia's company. We'll see about it. It's not impossible. So in the immune system.
Thank you. A couple of slides for tonight, mainly because I wanted to share with you what actually does it mean to have a drug and make an anti-aging drug, because it's very different. Aging is not delay disease. How can we get a drug that works in some disease to actually be a drug that can be expanded in anti-aging? So I'll tell you a little bit about myself, and then I can tell you a bit more about my new company. Stock at Stanford University, where I working on Down syndrome, and we found out that Down syndrome is actually age faster, and so we started studying how stem cells are actually regulated in Down syndrome, and we found out there was a specific gene that was strictly type of aging, of accelerated aging in Down syndrome. We have Alzheimer's disease, we have osteoporosis, alopecia, we have skin aging, and so on and so forth. So it was a really good model to start studying aging. And this was the foundation of the discovery of my first company, Dorian Therapeutics, which I founded together with Maddalena, my dear friend and co-founder. She's now back in Italy. But it was then acquired before the summer. A very big startup with very it was very exciting. They're fantastic, and so they took our project forward, and we hope to see some medicine coming out of the work that they are doing with the God Italian. Talking to her and she presented a lot of very interesting data. Professor at NYU, Salverini, and we heard open companies called ProMind Therapeutics, and we are protein metabolism for a healthy brain. If it goes too specific, do we go from finding something in the lab to actually have a drug for a disease, and how can we expand it to actually be an anti-aging drug? Good? Okay. So did it ever happen to you guys to a movie and remember everything, remember every scene or every second there is an increase in neurodegenerative diseases, so which include different symptoms, loss, cognitive impairment, and actually difficulties in performing daily tasks. So unfortunately there is no cure today to stop or reverse worry. So guys are not able to communicate very well. And then in the big bucket, there is the bucket of proteins. Proteins are just little proteins, they talk to each other, neurons talk to each other thanks to proteins. So what happened as we age, and we ended up having an additional way of looking at diseases. I'm going to study this one disease, but a lot of different diseases. And if we can solve therapies against specific diseases, for example, Alzheimer's, there are developed a lot of that are present in the brain, and this drug works very well. And this is the example of 2 clinical trials of patients. Fantastic. But actually, of the clinical progression. So it's not good enough. So this way of we should see improvement.
So the hypothesis was
that there should be something else. So we're working very well. So this is where we're really doing consolidation. So 2 things that need to happen at the cellular level. What did you do yesterday? Who did you talk to? So really exactly the same object. Then you take the mouse out, and 4 hours after, you're eating the animal for 1 time before training, and this is what we observe. You need to remember the object. So this is actually impressive, and this is in healthy animals. So the next question is, and so the way of doing this is that we need to choose a disease. In this case, we're choosing a specific rare disease because of some different indication. We can then test a healthy individual if it's safe, or how do we have a healthy brain. So we need to learn Zia Giulia and this is one of the biggest issues that we have when we study Alzheimer's disease, because the animal models are very bad models. There are some models that are easy to translate into humans. That's why we are starting from a different indication. We don't develop Alzheimer's, even if we induce it.
They develop a neurodegenerative condition that resembles you.
Is there a genetic marker to identify that one is?
So this is why a lot of
My story. I can tell that story, but not tonight. All the related scientists in the family, so inspiration, and I want to kill aging. And I said, oh, well, good luck. but we can help you. And gave me a real microscope, and then I have chemistry kit, an atomical model, and I started to play science, but I never stopped. Actually, I'm still doing it. Less naive than back then, but the whole career has been focused on that. So the scientist started working with actually Rita Levi-Montalcini in one of the labs under her patronage on brain aging and neurodegeneration. Then I continued until they called it Stanford. It was at Padova back then. We actually studied Bologna, then at Padova, PhD in neuroscience and aging. And then I called it Stanford, and I wanted to be in Italy. So I said, oh, I'll come only for 1 year as a visiting scholar. And 2 weeks later, I said, I love this place. So I want to stay. And that was 18 years ago. And so I stayed in a postdoc there, and I had the chance to open my lab, directed the research center, became a faculty, and then I thought, one of the other things I wanted to do is to make the science useful to people. And academy is a great place to discover, not really the best place to translate this to. So, and I did so. Last couple which I'm talking about tonight is the last of a series, because I started when actually doing a PhD. I was still in Padua when I started my first startup, and I did others. A couple here at Stanford, actually two here at Stanford, were actually two are involved also with Ron John. We've been in adventures together on that. Longevity. Right? The previous company is based on epigenetic reprogramming. But the one I'm talking tonight, which is called Turn Bio, sorry, that's the previous company. The one I'm talking tonight is called Rubedo Life Sciences. And it's exciting because we are in the clinic. So it's a big, big milestone. So we are actually testing this in the best animal model where you can test a drug, which are humans. So I'll tell you a bit more about that. But what are we doing at Rubedo? So there are many aspects that involve aging. Aging is a very complex, multifactorial phenomenon, like Ron John said. We don't really still understand it. We have ideas and models that are probably enough to approximate and try to target mechanisms of aging, but we don't have a full picture of it. But a simplified model, which I actually don't even love, that is called hallmarks of aging, which is how to kind of reduce that to simple mechanisms that are actually all interconnected, where you change one and everything else also shifted. One of these important hallmarks is called cellular senescence. And so what it is that any cells in our body, because of results of stress and damage in many forms, they become senescent. So people call them zombie cells. Again, don't love this, but it was on Nature, big journal, that's what they called it, and now it's stick to the, let's say, non-scientific terms. Why zombie cells? Because those are cells that stop dividing and they don't die, even during development. But as an adult, they stop dividing because they prevent the cells to do damage. Right? It could be a mutation to your DNA, and that cells could become cancer. So it's a tumor suppressor mechanism. So it's a good thing. Or it could be a damage to your, telomeres that gets too short, or the mitochondria, the energy factor of the cells that can make the cells pathologic, etc. So that's a good thing. But it's a double-edged sword. It's called pleiotropic function, because it becomes also bad. And that happens when those cells, because they don't die, if they are not removed by the immune system, and that happens with aging or with disease, they start to accumulate. And so that's a real problem, is that they don't just sit there but they start to secrete factors like toxins for the body, which again, it could be a good thing because it's a signal for the immune cells that says, I'm here, get rid of me. Right? There's something wrong, I stop, hey, come and find me. But again, in certain diseases and with aging, immune cells ages, and they don't see them anymore. And those senescent cells just keep building up in your body, and they keep secreting those factors. And so they're one of the reasons why we become chronically inflamed. So they keep driving this chronic inflammation that suppresses stem cell function, and it's the beginning of the end. So it depends on many manifestations, but they're behind the degeneration of diseases of the brain or the muscle of the heart, of your kidney, and they spread more cancer when they start accumulating. So that's a problem. Now the solution, what we do is that we found ways to get rid of them. There are many types of senescent cells. So we built a machine. It's based on AI and technology where you can look at all the genes and everything that happens in the metabolism at the single cell level. So every cell in a tissue in the body can be now analyzed. But we generated so much data that we applied AI to make sense of it. And so we had a pilot, we had a CTO that was one of the leaders of Facebook, Meta, for example, that we brought to build those tools that didn't exist. So now we know what are those different types of senescent cells, zombie cells. And we also know how to kill them, because they're all different flavors, so we can make different drugs for different use. So for your lung or your heart or muscle, brain, or your skin. And that's where we started. We are testing first in the skin for skin aging, because it's easier, before going into other conditions. And but we are in this clinic right now. It's a new drug, it's the first in class, so it's something that was never tested before. It's a new target that we discovered to kill certain type of those zombie cells. And what is interesting that in the skin, you can test the diseases. And so what we're doing is called basket trial. So we got approved to keep healthy volunteers, which you typically have to do, right? You have to start with safety individuals to test if it's safe. And then you have to do another trial with more people that have a disease. We were able to shortcut that. And we're now treating patients immediately, so we can test safety and efficacy at the same time in multiple diseases. So that's why basket trial. Diseases like chronic psoriasis or dermatitis, alopecia, but also testing the healthy skin for skin aging, which is not just used for therapeutically, but also cosmetically, to keep the skin healthy, reverse this degenerative problem, chronic, and becomes a disease. So we're testing this right now. We already know that the drug is safe, but we're now also looking into efficacy. And I can't reveal much tonight because it's still ongoing, but it's definitely exciting. And then we have other things like chronic pain and the neurodegenerative and metabolic disorders where those zombie cells play different roles. I'll stop here, and good question. And what we're testing right now is a topical first. So there are different drugs in reality, or molecules. One is a drug for therapeutics, so to treat diseases of the skin. But we have other similar molecules that we're working for cosmetic use. We did a deal with Beiersdorf last year. Beiersdorf is the parent company of products like to make the next generation of anti-aging Nivea, for example. But we also have
how long was the safety trial?
A single and multiple ascending dose, technically, meaning that you start with a small single dose and you wait and see if nothing happens, then you can do multiple doses. And we started the trial really was April, and we finished. And we did in different cohorts. So we started with the low, mid, and high dose. So we finished the high dose. So that's a fairly quick, and it's only 1 month's treatment because it's a phase 1 trial still. We will have to do phase 2 next year, but to compress much of this timeline. So safety is clear, that is at the highest dose so far. And now we're really looking at the effect in diseases like psoriasis or dermatitis, which is a age-related precancerogenous skin lesion. That is a great model for aging, for example, in the skin. And in all these patients, we're looking also in a healthy skin, but at different ages, especially in the elderly for skin aging, and see if the skin is reverting the biological aging. So we're looking at biological aging clocks. There are ways to molecularly looking at the biological age and cellular age, but also if the skin looks better, like thicker, if the wrinkles disappear, if it gets healthier, less inflamed, etc.
What do you think that you have something that works? Can you tell us why you've been waiting all these years and nothing has come out?
Yeah, it's a great question.
Can you repeat the question?
Yes.
Yeah.
So most of the senolytics are not, it's been probably 5 years ago we were hearing a lot about those senolytics, so drugs that remove senescent cells. But we don't see any product approved yet. And so what's different what you're doing? So how the field started was, I think, premature. It's really like in the 70s, 60s, 70s with oncology, where people thought about what's the best chemotherapy. Let's kill all cancer cells. That was like 50 years ago. And there's really the way it started in the senolytic field. Everybody was like in a gold rush to find the best way to kill senescent cells. When I started this company, and I remember pitching to investors, they would say, but isn't really this company? And I said, well, I'm afraid they're not going to make it. Because they're just thinking naively. Senescent cells are complex, there are many types. And so we want to be the tools first to find them, to fish in the right pond and know how to take the right fish. And history proved that this was true because the first generation of senolytics were repurposed from the cancer space. So toxic, non-specific, tested in animal models or in vitro models that proved not to be translating human conditions. There were not enough human work that's done. So we wanted to approach it differently. So our platform is, we call it Align, is all based on human data. We generate single cell, we have like 1 million single cell database generated from humans across diseases, tissues, conditions, and many ways to analyze that to try to be very specific. So we hope that our drugs will have that level of safety, which seems to be the case, but also selectivity, surgically removing only those zombie cells and protecting the good cells. So the idea that they're not made only for sick people, that's where we start, because that's where you can measure an effect easier. You don't have to wait 10, 20 years. But they're designed for healthy and younger people. Because if you don't have zombie cells, those drugs shouldn't do anything. Only as you accumulate, you get rid of them before they become dangerous 10 years later, 20 years later, or longer.
So question for Ron John, I want to hear from all the panelists. Ron John, you have tried many things. Everything that is, almost everything that is on the market in terms of supplements, vitamins. Well, and maybe something more than that. What works today?
I'm not sure we do. Do we ever do the standing on one leg test? What works today? So what Sylvia's saying is there's the future. That typically takes 20 years. With these new tools, maybe we can get 5 years, 8 years. But what can you do right now is red wine as a solution. I've tried pretty much everything, every supplement. I've been sequenced 3 times, the full body MRI scan, the microbiome's been analyzed. I'm part of this study at Stanford where they measure everything about you all the time. So I went to Professor Snyder 8, 9 years ago. So, but how long is this trial? Oh, 5 years. Well, it's now 8 years. And then what do you have to do? Oh, you just have to wear this watch, write down everything you eat, and take deep profiling. US initiative to collect genomes from 1 million people. But can you get deep profiling? How much exercise are you doing? And looking at your blood metrics. Turns out that if you start behaving yourself, blood metrics improve. The protocol that I imposed on myself was when I went for no sugar, which is like between Thanksgiving and Christmas, no sugar. And my family did it together. We don't, and then vegan diet at the same time. Within 2.5 weeks, my cholesterol went from, it was okay for mine, it was like 165. We went to 130, which is combined, of course. You have to sort of split it into different types of cholesterol. But that was only in 2.5 weeks. And conversely, if I fall off the wagon and I'm not doing my exercise and I start eating Ben & Jerry's, within 2 weeks, it comes way back up again. And there's a concept I like to think about. There are some things that are variable, that can go up and down. But some things are mechanical. Once it's gone, it's gone. You actually can't go backwards, right? So, type 2 diabetes, if you get your A1C, some of you may have seen it creep up a bit and get it back down again, creep up again. Well, I'm a big fan of measuring stuff because it encourages you to do the right thing. But once you break, 7.58, it's actually really difficult to get it back down to that level. So there's a mechanical, it's in other parts of the body, your cartilage. Now, if you don't do any running, then your cartilage goes away. If you do too much, yes, it also goes away. But it's a mechanical thing. You need some of it there to build on. The other thing I've used is alpha-lipoic acid accentuates all the antioxidants with vitamin C. It seems to make me less hungry. And then one thing that I'm using right now, it was something called GLP-1. Has anyone heard of that? But I'm not using Mounjaro. I'm not using any of those. It's one of my companies, and it's a GLP-1 agonist. It's the same thing as the prescription, but it's a food, and it's a pill. And so instead of having an injection, and instead of getting a prescription, you just have this pill once a day, not once a week. And it's a fraction of the price because it's made of food.
Why do you think that?
Oh, no, exactly. So what I see is I feel less hungry. So it's been helping me get down, and I'm probably at 165.
So you're cheating.
Everything's cheating. Everything's cheating. I said the aging vaccine. About 2 years ago, I was at a talk kind of like this, and one of my fellow scientists said, I think the first anti-aging drug, this is 2 years ago, so do you know that, is actually GLP-1. That's the starting gun, because at first it said, oh, it just helps you lose weight. Now there's all kinds of studies. It reduces kidney aging, reduces liver aging, it reduces heart disease, all kinds of studies that GLP-1 is a common factor across many, many, many diseases. So your question, why do you take it? It's not just the weight loss. And the debate among scientists, is it the weight loss that's causing the improvement? Because, your cardiovascular disease probability is vastly reduced as you lose weight. Or is there something in the chemical pathway that's helping you independent to your weight loss? I don't think we really know the answer to that, but when I talk to a GLP-1 sort of scientists, they're firm believers that it helps. It's not just the weight loss part that's causing an improvement in your aging. So that might be the starting gun. I think we're going to have much more improved systems. I'm optimistic in the next 10 years. I talked to my kids and people below 40. Do you have any people below 40 here? So you live forever. You actually live forever if you're below 40. If you've got kids, my kids are 21, twins, they will probably live forever. And so what does that mean if you're going to live forever? You think it's impossible. You thought language translation, real-time language translation, is impossible. Doing the speech recognition and then translate it to a different language. Now you can get these Apple AirPods. It does it for you right now. What was impossible 30 years ago is now possible. And so there is this concept of escape velocity. But you only have to get another 15 years, and during those 15 years, you get another Marco come out and Bonetto come out with their things and to solve the solution.
So do we get any insights from these famous blue zones? So in Italy, we are very proud to say that there is people in the mountains, people in Sardinia who have.
So I'm not sure what my colleagues want to comment. There was about maybe a year ago that said, well, I actually still believe the common element is low stress amongst all those blue zones, low stress, social, and sort of happiness. They call these at Stanford as the Center for Lifestyle Medicine that looks at a medical concept. And there's 5 lifestyle concepts. 1 is exercise, 2 is diet, 3 is sleep, 4 is social, 5 is low stress, and they even have 6 and 7, forgiveness, right? Don't have dollar reactions to nickel problems. But there was about a year ago, a paper came out and said, well, all the data was flawed and all these people didn't have real birth certificates and blah, blah, blah. And even if there's some mistakes in the data, I think intuitively I feel that it's probably the lifestyle medicine similar across these zones. But you can do that here. You don't have to go to Sardinia. Yes?
So I love all of this, science and the ability to, think about, slowing down the aging process, but who's looking at the societal impacts of living forever? And are you guys working with anybody in different
Of course, at
departments?
Stanford, we have one of our aging is covered in about 6 different centres, and one of them is actually called the Centre for Longevity by Professor Carstensen and Professor Ferguson. It's all about demographics. It's all about the implications of intergenerational strife. If you want to live forever, I went on a program. How did I learn about medicine? I'm an engineer. Well, Stanford has a program where you can go back to university in your 50s, and 60s, and 70s. And that was after you've got a 30-year career. If you're going to live to the 100, maybe you need to get re-educated in your 50s and 60s. And it may be something else. Are you going to stay married to one person for 150 years?
Now that I don't think the point is really not necessarily living forever, but it to extend health. So it's not lifespan, but health span first, right? Well, yeah, think about it. But I think just upfront, it's not just why we're doing it, it's because it's already a socio-economic crisis up and coming, right? The population is growing, and mostly the population that is aging is growing, and more importantly, the population that is aging with chronic degenerative conditions. You know, in countries like Italy, for example, we already passed the population over 65. It's already higher than the population younger than 5, and this trend is continuing. So, who is going to take care of a growing, sick, older population, right? And if we don't have an intervention now, is a socio-economic crisis that is unsustainable. So that's really the goal, is first shift this cost, which is personal, emotional, not just financial, right? For individual, family, and society, and just postpone it in time, or even squeeze it to the very last year, maybe, of life, instead of the last 20 years of slowly decaying and losing health and function and vitality and then independence. It's a very bad cycle. I think that's really what we will see in the not distant future, which comes with questions about how society will change, for sure. But there is an ecosystem of, like John said, at Stanford and really around the world that is working. Also to educate even physicians, for example, how to think differently, educators, how to teach people, and really adding a new generation, arguably the wiser population in the society, that instead of having to retire and kind of disappear, will contribute and keep being active. Doesn't mean like I have to work forever. No, but you will change what you can do, what you want to do, and how you help the new generation. And so I think it will be a society change.
So how do we make sure that people don't have kids after 100?
Yeah, actually, the kids, I just looked it up. There'll be some countries in the next 30, 40 years that will literally be extinct to have aging solutions. I just looked up Italy. Japan, yeah, South Korea, Japan, the replacement rate's 1.2. Italy's also 1.2. Korea is 0.75. South Korea.
And Hong Kong.
So that means 0.75. If you have 60 million population, in one generation you're down to 24 million. 2 generations you're down to 10 million. That's what South Korea is looking at. So all these countries that say no immigration, these dictators, autocrats, they'll literally go out of business. There aren't many people to buy the product or do the work. But so there'll be an intergenerational kind of dynamics.
Benedetta, one question before. Is aging gender aware, and is longevity gender aware?
It's a very good question. Very good.
By the way, we did not prepare for questions, so it's okay to say I don't know.
So definitely there is something that I'm very excited about that is going on in the last probably 2 to 3 years to really understand women health compared to men health. Because all the majority of the studies are usually done on, for example, just animals. So you use males because they don't have hormone changes, so it's just easier. The data are not consistent. The women have a lot of hormones going on and so on. But actually, there is a lot of companies that are coming up now really studying what happened to women health, because of course there is changes in hormones that is very different from men, and it's so that women live longer than men. is it, and what is the science behind it, how much hormones have a role in these. We do have osteoporosis higher than men, so there are a lot of different, aging is different in men and women. Overall, women live longer, but there are different problems that they have, and I'm very excited of seeing this huge change in the way of, there are a lot of companies that are studying menopause, how does it happen, how is it changing the body. The NIH is actually, when they release grants, you need to do studies both in male and female animals, so to make sure that there is a good representation of both and you understand how hormone can change. So I think that is the thing that we're going to see most of the changes sooner than other things. And I think it's time for it to be there. On top of these tools now that allows also to have non-invasive analysis of changes in hormones and how the human changes. There are a lot of biometric assessment that can be done that couldn't be done 10 years ago. So definitely sensors allows the study of this in much more in humans.
There's a question there.
You can't drink red wine. If you can't drink red wine and eat prosciutto, is life worth living? But my real question actually gets to some of the implications from the insurance industry and what reactions you've heard or seen from them. Because on one hand, what you're talking about could be potentially very beneficial. Extending the healthy lifespan is a good thing if you're an insurance company, right? Because less claims, less chronic disease, etc. On the other hand, it extends potentially the period that you have exposure to a patient. So what's the reaction from that industry?
I've actually asked, and there is an anecdote to Jean Coleman, who's the oldest person who ever lived, got to 122. She did a deal, not with a company, but with a lawyer. It's what's called a reverse mortgage. If you keep paying me until I kick the bucket. And so he ended up paying 3 times the value of the house, and his estate had to still keep paying for 2 years before she died. Now, I've asked insurance companies, like a reverse mortgage, suppose I live to 140, and you've only calculated till 96 or 76 is the average age. What's going to happen? And they said, no, don't worry, we've got it all hedged. We've got it all hedged, everything's calculated. And I said, I thought that's what Silicon Valley Bank said, right? So can't trust anybody, but I'm not very convinced with the response when I've talked to insurance companies.
And so I think there's a paradigm shift in how medicine is. I call this medicine 3.0 more than longevity medicine. It's really like shifting from a reactive medicine, which is you wait, you get sick, and then you treat it and you pay for it, versus a preventive medicine. And insurance is, just even an example, Kaiser, which has now a huge database of hundreds of thousands of patients tracked longitudinally over time, and even Stanford has a program where you get rewarded if you take actions that keep you healthier and better wellness, which lower the risk of developing disease. So your premium changes and the cost of insurance changes. That is meaning more sustainable over time. So insurances are thinking how that can be, because they can actually save money. Yes, if they have to keep someone under insurance for another 10, 20, 50 years, but paying very little, like when you are in your 20s, 30s, or healthy 40s, etc., the model is still perfectly working, and it's more for injuries or traumas or situations where you still need a reactive intervention, but you can keep your baseline at a healthy state for much longer. The major cost is chronic degenerative diseases. That's really is a major burden.
One of the biggest problems, something that I think we should work on, is really understand what are the biomarkers that allow us to, in shorter time, see whether we're preventing something. Because today we cannot go and have a clinical trial on preventing. Okay, we need to follow a person for maybe 30 years. It's not sustainable, it's too expensive, so it's very difficult to do. So I think that if we can really invest in understanding what are the biomarkers, this can really allow us to open up to a preventive medicine that today is really difficult to make.
I have a question on, you read about all these billionaires taking metformin and all these things. Is that all snake oil, or what are your expert opinions on things like metformin and these other supplements and stuff?
Well, I'd say the best answer is you cannot do biohacking without being followed by a physician. because we're very different. And what you read, like metformin, it's safe, yes and no. There are side effects. There are populations that are actually severe side effects. If they're healthy actively physically, data show that they can blunt or prevent the benefit of exercise. And it's really about metabolism. Metformin is a drug for diabetes. So where is your metabolism fall? So you're closer to diabetes or you're somewhere else. So you may not need it. So aging is different. We have different trajectory of aging. So that's where we're going. As we understand, we will know what type of intervention, when and where is needed. So when people say, what do you take? I say, I might do things on myself, but I track myself and I follow, and also training and physicians that follow. You cannot just take bluntly things. Supplements, most of the time, is just very expensive water, or you generate water when you go to the toilet and do it. But you have to be careful, because there could be long-term negative impact that you don't know. And some of the supplements can be actually drugs, so they've never been tested properly with a claim of an indication. So my advice is always like, don't try things because you might hurt yourself without a physician or someone that knows what you're doing and without measuring.
And I bet there could be interactions with other drugs.
Absolutely, absolutely.
I actually have an app that can put in all your supplement and tell you if it interacts. I think Mark has, if I was 85, 90 and I had things to worry about, then you sort of look at those kinds of things. If I was, diabetic or close to being diabetic, maybe I'd look at those things. So it's on the radar, but I said, why do it? Why take all the side effects? Why risk it? But it's on the radar. And the other aspect is that there's a concept known as ageotypes. There's again a Stanford concept. So some of us are heart agers, some of us are kidney agers, some of us are lung agers. Unfortunately, some of us are all of the above. If you find out what kind of ager you are, and that might be some hints. You seem to, chocolate cake, you sort of balloon up. Some people, they eat as much as they want, nothing happens to them. And then other people, maybe in their family, if your mother and your father had this disease and your mother's, everybody in their family chain, well, maybe you should watch out for that particular thing. And then you can look at things, what could help. And there could be supplements and medicines and things. There's some of these extreme cases where people, it doesn't work. Often those people are might be like Marco, he exercises and behaves himself. And so if you're at that upper level, you're not going to see much difference. So I always think, how do I get to be like Mark? How do I get to be the upper level? And that unfortunately means behaving yourself, diet, exercise, less red wine.
I have bigger problems. I think in my life is much better than me. But yeah, I don't take any of these. And again, sometimes I think about my grandma, my Zia that I showed you. She told me she never ate anything that was green. Was always having red wine and salami. She was saying very dirty jokes. And she said, I'm 100, I can say dirty jokes. Oh, no, you're 100, you cannot. This is how it should be. And it goes back to, am I going to get metformin when I'm going to start having 8 hours of sleep? I don't have kids coming in the middle of the night. So I think that sleep well, eat well, exercise, the usual thing that grandma says. So socialization is really something that I think it's really important. The example of Sardinia that you were mentioning, I really feel that this could be the differential of how we live. We have the aunt over there that can take care of the kids if you need to do something else. You have the grandma that cooks for everybody. I think that this is really community. And this is a purpose and sense of belonging and not being alone. I think that this is really when I go back to Italy. I go back to Italy to my family. There is more communal. There is different feeling. I really feel that this part of community is something that especially American probably needs to work on a little bit more. And we have lunch that lasts 3 hours. The beginning of it, just chill out.
We had a session like this was a year or so ago, this year, and we talked a lot about a couple of things that didn't pop up today. One is meditation. The other is intermittent fasting, which seems to have gone a little bit out of fashion. And then sleep, which we know is extremely important. It's not just the length of sleep, the 8 hours, but also the regularity, the consistency of going to bed at the same time and waking up at the same time. Any thought, comments?
Yeah, I'm a big fan of what to do. Diet, exercise, sleep. We all know what to do, but we still probably go to bed at 1 a.m., 2 a.m., and wake up at 8. I'm actually a big fan of these now wearables. I used to be cynical about them because I'd wear them, put them in a drawer, and not use them. But basically, it's the nudging effect. It's saying it's time for you to go buzzers, time for you to go to bed. And the other thing I do, I like to check yourself into a trial. There's hundreds of them in Stanford, hundreds and hundreds of them. And check yourself into a trial, and you get all this data measured for you for free. And there's 6 or 7 people looking at you instead of when you go to your doctor for 10 minutes, right? You can sort of find something that may be interesting to you, and that's what I like to do. Usually they're quite interesting, so we can send some links actually. Yeah, but I've got more of a fan of these things that I wear, and that's Marco said, just measure everything. Yes, that's what the sleeping. I haven't got one of those, but yes.
Yeah, so living in the private company, early stage life science company space, just want to change the trajectory a little bit about the conversation about attracting investors for early stage science. Now you're at Altos, we know the CEO and we're former Genentech and so on, but given the climate that we're in now with the NIH and the administration, but early stage startup life science companies are trying to get investors. Can you, all three of you, talk about your individual experiences? We're part of Stanford Spark, and we're working with a bunch of early stage stuff. And so I'd love to hear your journey or what your thoughts and perspectives are in this very challenging climate that we live in.
Certainly, I lived through the different stages. This is really, really hard. This may be, for biotech in particular, the worst historically. Nuclear winter in the finding that we are experiencing for a number of factors and reasons we can talk about. Generally, there are always cycles, but those last like 1.5 years to maybe 3 years, historically the longest. We are at the almost 5th year, which is really drying the resources and the whole cycle, right? Because every stage is actually the foundation for large, big pharma. They need to acquire to build a pipeline innovation. But we start to see some improvement now in M&As, but mergers and acquisitions. But then I've been doing conservative, and in the meanwhile, their IP is losing longevity, and they're losing their main drivers. But if they don't do it, they don't re-inject the capitals that a startup that grows over time collects and then multiplies and brings back into the cycle. So this hasn't been happening for too long, and it's certainly really, really hard right now. We've seen lots of companies dying, struggling. So I've seen this, and because I'm exposed in multiple companies, I've seen the good and the bad, no doubt. I think we're lucky. We actually just closed another financing round right now on the Series B. Series B. If you're interested, there is still many others, etc. But it's been definitely much harder than in the past. We'll see. We talk to all the colleagues and we see the companies are all struggling. It's really, really hard. You need to work like not 10 times, 100 times more to get much less. Valuations dropped. I mean, and when the investors are investing, they're putting a clause that they can be really aggressive. Seeing all the other, but everybody is also trying to protect their own portfolio so they don't invest in new companies. And as a result, nobody's investing. So it's really a frozen time. It's really hard, and there is a need of something new happening. GLP-1 has actually been a big blockbuster and is driving a multi-billion market. And this year in Copenhagen at this age-related drug disease conference, they came, which is one of the main in the field of age-related drug discovery. They came present and they self-declare, but we all agreed, that GLP-1 agonists and their drugs are the first longevity drugs. But it's kind of true. And so this is kind of helping, but there is need for more. And I have to say the AI boom and bubble is not helping because it's like draining lots of resources, sucking the oxygen out of everyone else, including biotech.
Okay, yes, I'm an investor and an inventor at the same time. So here's the landscape. There's 300 companies on the public stock market you can just buy that are trading less than cash. In other words, they're trading at negative valuation. So why would I invest in Marco when I can get a company for free, for negative? Because he's brilliant, that's why. So you've got that headwind against you. On the flip side, Marco's correct. There's $300 billion pharma about to go off a patent cliff in the next 3 years. So if you're smart, if you're a farmer, you should be, usually pharma buys at phase 2. Because at our stage, at Benedetta and me, Preca, we have a 95% chance of failing. It's 1 in 20 chance of succeeding. And that's too risky. Even if your name is Pfizer, it's too risky. They'll buy you at phase 2 when there's a third of a chance of succeeding. They'll take that. So it's cheaper for them to have all of us invest in startups, in our small companies at the beginning, and they'll pick up the best. They'll pay more. They should be buying earlier because they'll find there won't be any companies that have all gone bankrupt. And the ones that are left are going to be a higher price. Now, really to your question, at the very earliest stage, with the first check, you only check quite often. Now, we invest very small amounts, 50K, 500K, that kind of range. And we're asking companies, what can you do with that? Now, we had one company that we didn't invest in it, that raised about 140 million. And we had another company who raised about 180K. They're about the same level. Why? It's because they've been a bit smart about it. They said, oh, let's go to a university. Oh, there's this drug about to hit. It's about to go to phase 1. And all they want is 4% of your company. It's like the university. Off you go. Scan the landscape. So all of a sudden, that's just wiped out $10 million of investment you would have had to make. And you're way ahead. So being a bit more savvy, a bit more smart. The other technique is instead of just doing your trial here in the States, wandering around the world for the right research organization. They've already done the experiment, but in a different context, in a different country. So instead of being a $5 million trial, it's a $500,000 trial. So we have to be, you've got to hustle. And that's what I would say to the first early stage companies. In the Spark, I'm very familiar with the Spark program. I attend it. And then the final thing is make the story simple, right? If you say I'm using computational techniques for a epigenetic reprogramming platform, then know what I'm talking about, right? And the other thing, don't fight the AI. Sometimes I talk to my biotech portfolio companies, and they'll say these biotech investors, they have no money. You need to talk to AI investors. Us AI people, we're arrogant. We're arrogant. We say we're going around. There's like 2 Nobel Prizes got awarded for people who are not in chemists and not in physicists, but the AI people say, well, you've just been doing it all wrong these last 20 years. Just give us the data, let us have a go, right? And that's the personality of an AI person. Now, of course, it's a mix. You need to. But those are my comments. You're not raising money.
I agree. Exactly. I agree with all that has been said. My feeling is that as pharma are moving further away and they're taking less risk, investors are the same. So if pharma are moving toward phase 2, investors are moving toward first in human. So let's say Series A right now, you need to have human data, while I would say 5 years ago it was not like this. So as the gap is becoming bigger between the university and the pharma, of course, investors cannot cover for all, and they also are moving away from risk more than how it was at least 5 years ago. Okay, thank you. Let's thank the speakers.